I've been asked to just come and just give a short welcome because I am a member, as has been said, of the Health Committee and the Committee Social Development Committee. And I just want a very warm welcome to Parliament Buildings. You've brought the sunshine with you, thankfully, because sometimes it can be very dreary up here. So it's nice and bright today, so very welcome. This seminar is particularly timely given my own background in social care, and that both committees that I represent have concerns about how Northern Ireland can, in the long term, effectively and fairly meet the needs of those who require social care support. Adult social care is a devolved matter that affects us all. We all know someone, a family member or a friend, who may need some extra support to lead a full and independent life. At present, the Government provides a range of adult care services. This might include housing services, social security benefits, acute and community care services, and support for carers. In addition, our society depends heavily on the individual role paid by unpaid carers. However, adult care support provision in Northern Ireland is coming under increasing pressure for a range of reasons. These include the increasing ageing population, growing expectations about levels of support, and the challenging financial climate that we're in. Given this, it is widely believed that our current care and support system will be unable to cope with the demands of the future unless significant changes are made. The Government is currently taking steps to address these issues. In 2011, the Department of Health, Social Services and Public Safety set out an overall vision for health and social care. This was called Transforming Your Care, and I'm sure you have all heard about that. It's not something that we can easily ignore. The aim in TYC is that more people will be cared for at home and in their own communities. In addition, one of the major principles identified in TYC was to promote independence and personalisation of care. It is suggested that this will enable people to discuss the budget available for their own care needs so that they can get services which are right for them. More recently, the Department of Health also published a discussion document inviting more debate on social care issues. This was entitled Who Cares? A key part of the document concerns on how funding for such services can be made more sustainable for the future. Now, this leads me nicely on to introduce Dr. Anne-Marie Gray, who has examined this adult social care issue in great detail. As members up here in Stormont, we're always interested to hear what the policy research is telling us and how it can inform our committee and the way we work and the decisions that we make. So without much further ado, I'm going to welcome.
Thanks very much for introducing me, Paula. This is probably an interesting week, I think, to be doing this talk, and I didn't anticipate this whenever I put my name down for this subject way back in September, but I think it's a good opportunity. What I'm going to be looking at today is not specifically older people, and it's certainly not specifically residential care. Rather, I'm going to be looking at adult social care as an increasing priority area within social policy, and at some of the developments which have taken place across the UK with regard to adult social care, and then specifically focusing on personalisation as a key theme. And as many of you know, personalisation through personal budgets specifically has been in operation in England for a number of years now, and some of the research around the workings and the operatisation of personalisation are beginning to emerge now, and I think there are some interesting issues. Of course, the factors behind the focus on adult social care are probably well known now to most of us. We're continually told about the demographic change, the growing number of older people particularly, but also for many years now, people with disabilities, people born with disabilities, have been living in the community as opposed to going into residential care. But there's other contexts as well. There is a context, I think, across the UK of welfare retrenchment, and I think this is where we need maybe to start to put in some provisos and to put in some question marks, because I think the fact that we have, certainly at Westminster, a government which is fairly committed to cutting back the welfare state means that these policies are being implemented in a particular context. And very often, and I'll come to this later, in several policy documents, we do see reference to social care as a cheaper way of doing things. and yet I think the evidence is very much to the contrary, that good care in the community is not a cheaper way of doing things. The values linked to personalisation and to better adult social care, few people would really disagree with, and particularly the promotion of independence, that people should have more control over their care, should have more say, and should, certainly if they can't or they don't wish to take a budget to buy the services themselves, that they should still be able to have a say over how those services are provided and by whom. But the other context too, which has been driving forward adult social care policy, is a recognition that things are not good in many respects. That there have been concerns, and the research have highlighted these concerns, both about access to services, whether people in the community are getting sufficient time in terms of domiciliary support, the quality of care in residential and nursing homes we've had for older people, but also for other client groups. And just in the past year, just actually as we were doing the book, there just seemed to be a series of scandals around Winterbourne View and around other areas. And here in Northern Ireland, we have the Human Rights Commission publishing its report on nursing care, and the Equality and Human Rights Commission in England publishing its report on domiciliary care, and all of them raising issues about quality. And that's not to say there's not lots of good practice, but inevitably those things are important as well. So, in terms of policy, this is an interesting area of social policy, I think, but it's a very, very neglected area of social policy. And even if we were to go right back to the introduction of the welfare state, the setting up of the National Health Service, very little was said about social care. And we've now still got that legacy. So we're not looking at social care just having got a bit behind in the past 10 or 20 years. Adult social care has always been behind. When the welfare state was created in the UK, initially there was a lot of emphasis on institutional care. And we in fact only saw, again as many of you know, the first community care policy at the end of the 1980s. So in many respects that's relatively new. But we do have, and for many years theorists, academics, policymakers have talked about the residualisation of social care services, and I still think that we are fighting that battle. And now we have the opportunities in the different parts of the UK to look at doing something about this. But we are doing it in this challenging context, in this context of austerity, of public expenditure cuts, and with the legacy that we have of 60 years of underfunding in adult social care. So, just to very briefly summarise from the research the key concerns that have emerged around current provision, and I think these concerns apply across the United Kingdom, that for a long time there's been concerns about entitlement to care and support, what people should pay for, what they shouldn't pay for, particularly in relation to residential care, how many minutes they should be entitled to in domiciliary care and so on. We've had those issues I alluded to in relation to safeguarding and risk. And obviously we want to ensure that people are protected, but not so protected that they can't be independent, that they're prevented from making their own decisions, and there's a balance to be found there, and it's difficult. The role of unpaid carers is absolutely fundamental to these discussions in adult care, because certainly the policy that was introduced in the 1990s could not have been and survived as a policy had it not been that the bulk of the work was provided by carers doing that free of charge or for very small amounts of social security benefit. And I think the question we need to ask is, can we be secure in the knowledge that there will be sufficient number of unpaid carers in the community? Maybe, but maybe not, given all of the other pressures on people in terms of welfare to work, in terms of economic pressures. Do we need to find a better way of recognising the work of carers? And absolutely yes, we do. And we don't need any more research on that topic. We have lots of research which has been telling us that. There are issues also regarding the paid workforce and the need for workforce development. Now, from my perspective, I think this particularly applies to the level of social care workers below the social work level. Like other parts of the UK, we've had a big emphasis on developing the social work workforce, the training, the professional development and so on. But there's a very, very large number of social care workers going into people's homes to carry out intimate tasks, working in residential homes, and we know very little about these workers. We know that they're, generally speaking, not well qualified. We know that there's issues around the retention of workers. We know that they're very low paid. And if we are really serious about developing, an adult social care policy which is going to last, then we need to look at the workforce and what we do about that. In Northern Ireland, we have an integrated health and social care structure that sets us apart from every other part of the UK in terms of health and social care. We have no sound evidence of whether that's working or not, or how effective it is. We assume that it is, and I think in many respects we should assume that. We think that if things are structurally integrated, that they should work better, and there's some evidence, perhaps in terms of better discharge planning and so on, that might point to that. But we don't have nearly enough research to make a good judgment about whether it's as good as it could be or what we need to do to improve it. And then we have all kinds of issues around the funding arrangements, not just for long-term care, but also around the commissioning of domiciliary care. And those are all things to do with aspects of social care work, but at the bottom there you'll see just reference to do we need to think, particularly in relation to older people, about why some of the practice has been bad practice, why some of the policies have been slow to develop, why it's taken a long time to get to grips with some of these things. And when the House of Commons looked at this, one of their committees, they found that many of the shortcomings in adult social care could be related to what they called a persistent ageism. And I know that currently in Northern Ireland we're thinking about age equality legislation, and so of course it's very pertinent to that. So if we were to look at all of the adult social care policies across the UK, in Scotland, Wales, England and Northern Ireland, I think we could detect these three themes. Personalisation is a very dominant theme, independent living, the integration of social care and other services, not just structural integration, but just effective working as well. And actually, one of the Minister for Health was interviewed the other morning on the radio, and they were asking him, would it not be better if we had structural integration? And they mentioned Northern Ireland, and he was quite ambivalent about that, but he did say they needed to find better ways of working together. And then the third theme would be enhancing user participation, not just in terms of decisions about services, but also policy. So I'm just going to quite quickly maybe mention policy developments in each part of the UK and then come on to Northern Ireland. And I'm really just drawing out the main components of policy change. So in England, I think we could identify those as proposals whereby there would be a national threshold for eligibility. And that came out of the Law Commission review in 2011, where the Law Commission was asked to review adult social care law, and they concluded that it was really disparate, that it was completely out of date, and basically it was dysfunctional. And they recommended fairly far-reaching recommendations, which for the most part have been accepted by the coalition government. And one of those is that there would be a national threshold of eligibility, which every user would be entitled to. There would be legal entitlement to a personal budget, and actually the thinking was that by this month, or by last month, by the end of April, that every person who was assessed as being in need of care in England would have access to a personal budget. And then a new statutory framework for adult safeguarding to try and address some of the issues which had come out of those various scandals, inquiries and so on. Now, a lot of things in the white paper in England are positive and have responded to academic knowledge and to an evidence base and to consultation. But there is this underpinning critical comment, which is that there was an almost total ignoring in the white paper of an existing crisis in adult social care in terms of people not being able to get services that in fact they were entitled to, of a rationing in terms of people's needs being assessed to meet a budget rather than being assessed in terms of their true need, as social service directors struggle to try and make their budget fit that need. And then the subsequent financial pressures that local authorities are being confronted with in terms of cuts. Now, I won't say too much about personalisation at this stage, except to say that, of course, England, compared to other parts of the UK, is very far down the road in comparison. The national evaluation was started of personal budgets in 2005, and it has been a very strong feature of every adult social care policy document since about the end of the 1990s with the new Labour government. And the Welsh Government has pretty much rejected the concept of personalisation as it's been rolled out in England. And they've talked more about a citizen-centred social services, rejecting what, their words, the strategy of retrenchment in favour of renewal, delivery and innovation. So they don't actually use the word personalisation very much. But what they're talking about is the same values in terms of user control and so on. The main criticism is that they see it in England as being too closely linked to a market-led neoliberal model, really, of consumer choice. But they are still committed to increasing the use of direct payments. And Wales has also recently acknowledged that it will also be enacting a legal framework for social services that, in terms of developing a national eligibility framework. And that's following from the English Law Commission report. Scotland uses a different term, and there is a potential for confusion around the terms used to describe personalisation. Self-directed support mostly relates to independent living, which is, an aspect of personalisation as well. And the Scottish policy is that self-directed support should be offered by local authorities to all those assessed as requiring care services, and that's the vision there. And they have recently published in Scotland a major report on integrating health and social care, which goes as far as talking about integrated budgets as well. Now, to come to where we are, as everybody knows, now we have had this Transforming Your Care review, so a big review of health and social care in 2011, and that anticipated that social care would be a very strong component of this transformation from acute care to care in the community and better public health and so on. Now, I'll just say at this point that for me what has been problematic is that we had Transforming Your Care and all the subsequent documents related to Transforming Your Care, so the consultation, the post-consultation and so on, which talked about adult social care and how it would develop. And then quite far down the line we get an adult social care discussion paper, which really sets out broad themes rather than clear policy. My view would be that those things would need it to have been done more in tandem. And it's very difficult for people to comment on an adult social care paper because of the lack of detail on it. But the Transforming Your Care review did note the limited progress in Northern Ireland with regard to personalisation, but it very much drew attention to personalisation as an outcome which was to be sought, and they drew attention to the need for a debate on the issue and on the issue of funding. Now, in England as well in 2011, the Dilnot Commission published its report on how long-term care should be funded. And that committee, and this has been a real, I think, difficult issue for social care policy for many years, but that Dilnot Commission recommended that people should ultimately pay less because there should be a ceiling on what they should pay, and people would have to have much more income before they would have to pay anything. So initially they were saying that the cap on what people should pay should be 35,000, Now, the coalition government accepted the Dilnot Commission's broad proposals, except that it has recently said that it would set the cap at 75,000, although the means testing bit is still over the 100,000. We have yet to decide what we will do in relation to the funding of long-term care in Northern Ireland. But we have now a set of broad principles for adult social care. We don't yet, as I mentioned, have any detailed discussion of how these would be achieved, or even, in fact, perhaps clear enough objectives. And there isn't yet a proposal here to introduce new legislation which would put social care on a statutory footing. So we're not yet talking about whether we need to have that national entitlement, if you like, for Northern Ireland. Still to be discussed, not just decided. Okay, so to move on then to look in a bit more detail at personalisation. So new words, I think relatively new words, but not new ideas. We could trace the ideas linked to personalisation back to the disability and user movements in the 1970s, that idea of independent living, of choice and control. And I think probably because the context, the economic context and so on, people now do talk very much about personalisation as about an individual having control over their budget, the budget with which they purchase their care. And there's a criticism has developed around that idea on the grounds that potentially that could make people actually more vulnerable if they can't manage in this sort of free market situation. And that personalisation, critics say, it's not about an individualistic approach to care, with people just being expected to manage on their own and to compete in that kind of market, but it's about the right kind of support in the place that people need it and when they need it. And it's about support which they don't have to rely on families to provide. And that's really the independence, so that you wouldn't have to rely on an unpaid carer perhaps, but that you would have an entitlement which goes beyond that. Now, a lot of people have grappled with trying to really explain what personalisation means in practice, but this is how the Social Care Institute for Excellence defines personalisation. I'm not going to read that out, you can see it there. But you can see the key features there are about active engagement in the design of delivery and in the evaluation of services. It's about maybe changing leadership and changing organisational structures and cultures in terms of professional attitudes, in fact, in terms of the acknowledgement that care ought to be person-centred. And then the word that we are becoming very familiar with about embedding re-ablement and prevention, that we support people at a very early level of need or a very early stage of need, so that they don't have to move into residential care, they don't have to move into institutional care, and that they can, in fact, because it's not just older people, it's working age people as well, that they can go to work and so on. And then a total system response, because it's not just health, it's not just social care, it's education, it's leisure, it's being able to be part of the networks in your community and so on. Now, some hard, or as hard as we've got data then, on how these personal budgets are working. Just to explain that in England, the way personal budgets have rolled out is that you can take your personal budget as a direct payment, so the cash is paid to you, and then you are responsible for buying your services, so you can purchase your care assistant or other services. Or if you don't want to do that, because the history of direct payments since 1996 has shown that some client groups and some individuals don't want to do that, that you will still be allocated a personal budget linked to your assessed need, but that the local authority or a third party, maybe an independent NGO, expert NGO, will manage that budget for you. You should still be involved in the decisions about your need and about the budget and how that budget is spent. So we've had the national evaluation, which people at York University published in 2008. And then subsequent to that, there has been a number of other sources of data about how these personal budgets are working. Every year, the Association of the Directors of Adult Social Services publishes their annual survey on personal budgets, who gets a personal budget, how much they get, and so on. It is a bit limited in terms of the data they collect, but it gives some useful information on usage. And then we're beginning to see now some quantitative and qualitative studies, I've mentioned some of them there, about what users are thinking of how personal budgets are working, what local authorities are thinking and how local authorities have had to adapt, what they might need to do in the future, and then what the expert organisations that are working, particularly with disabled people or people with learning disabilities or older people, to support them to take personal budgets, how that's working for them. So I'm just going to maybe flag up just some of the issues. I would just say that there is reference to one report there, Towards Excellence in Social Care Partnership, and they use a range of national statistics, but they also use other data, including more qualitative data. But the one thing that's been highlighted in a very major way in that report is the deficiency of data, and that if we're going to do this with better rigour, then we need to know more about how direct payments or how personal budgets are being used. We need to know more about the commissioning patterns of local authorities and so on, and a lot of that information we don't have a good grasp of yet. What we do know is that the number of personal budgets has grown. In fact, it doubled between 2011 and 2012 as local authorities really tried hard to meet the targets that have been set by government in terms of having everyone taking a personal budget by April 2013. What we also know is that there continues to be differences in uptake across the client groups. Still a small number of people with a learning disability taking a personal budget, and still smaller numbers of older people compared to working age disabled people taking a personal budget. We also know now, just from the most recent data, that the vast majority of those people who resulted in the doubling of the numbers between 2011 and 2012 did not opt to take their personal budget themselves. They opted to have the local authority manage the budget for them. Now, on the one hand, you could say that's choice, but on the other hand, we know from other research findings that the outcomes have been judged to have been quite considerably better for people who've opted to take the personal budget themselves, in terms of how they feel, how much control and so on they feel they've had. And there is some suggestion that local authorities have been encouraging people really just to take a managed personal budget because they saw that as the most expedient way to meet the targets that had been set. Now, across the research, we can see examples of some really positive outcomes, and there has been some fantastic innovation in terms of how personal budgets are used. So people have been using them to stay in employment, to get back into employment, to really broaden their quality of life in terms of social networks, in terms of holidays and so on. And carers as well have expressed a view that very often personal budgets has been a very positive experience for them. So the quality of life, yes, we can see that they can make a difference, and that the experience for people holding personal budgets has generally tended to be better than for people who are using conventional services. But then, as I've mentioned, the largest growth is in those managed by local authorities. Most people, we've got that innovation, but most people who take personal budgets are still spending them on conventional services. So they're still using them to employ care assistants, rather maybe than taking risks, to use that word. When the personal budget scheme was rolled out in England, what was emphasised quite considerably was that here was the potential to integrate funding from a range of different sources. So from supporting people, from the Independent Living Fund and so on. Now, the national evaluation and subsequent research has shown that there's been really quite substantial legislative and administrative barriers to that hasn't worked actually particularly well. And of course now there is, some local authorities have had their supporting budgets cut by about 60%. And then the future of the Independent Living Fund as well, which is not secure. And I've mentioned some of the outcomes there, but there is still, relatively speaking, quite poor evidence on outcomes, and especially, of course, on the longer-term outcomes. There are some specific issues around commissioning. I think when the concept of independent living was really taken off in the 1970s, it was driven by a group of very politically astute disabled activists, if you like, people who had a political as well as a social care agenda. And I think the research has still shown us that these are the kind of people who really benefit from these personal budgets. They're using it really well. It's been, tremendous positive experience for them. But for other users and carers who are trying to navigate a social care market, maybe people with very complex needs, or people who don't feel confident about doing that kind of thing, then there are issues in terms of the level of advocacy, how that's provided, how they can be encouraged maybe to have more of a say, at least, in what's delivered to them, to choose their own workers. Local authorities have a role as commissioners in ensuring a diversity of providers, and the evidence on that is very, very mixed. So in some local authority areas there's been innovation in terms of assessing the need first through the assessments linked to the personal budgets, and then going out to try and attract providers to meet those specific needs. So some really nice pieces of work by local authorities. In other areas, local authorities have struggled because, in fact, some housing providers in particular have left the market as personal budgets have been rolled out and people have been buying services individually. They've been concerned about the economic impact of losing block contracts and have just not providing or not making available those services. So the 2012 white paper actually imposes a set of new duties on local authorities to shape the market by providing a diversity of providers. They now have a statutory obligation to do that. And then we have still, in terms of commissioning, got this uncertainty that I mentioned because of the public expenditure cuts. So some of the questions that we might need to be asking about overall, so if we were to look across England, is there evidence that there's a better range of community-based provision than there was before personal budgets and personalisation? And then what about the impact on the existing traditional services? Because some assumptions were made that haven't actually been borne out. And I think that particularly one of the most interesting discussions has been around day centres. And initially local authorities were taking the decision that if more people were buying services and wanting to have this independent kind of care, that they could start to close down day centres or reduce day centre provision. And there's been the most enormous backlash to that from users who say that our day centre is not somewhere where we go to be cared for. It's somewhere we go to where we have social engagement with people. And that's taken away a big part of our lives to take that away. And there is tension, I think, in the research and in the academic and practitioner arguments about this, and the user arguments as well, because some of the strongest voices initially against day centres were from disabled people themselves, who they felt that day centres represented a one-size-fits-all idea of social care, and they were advocating, basically for the abolition of many day centres. But overall, there has been a lot of opposition in local authority areas to the decline in day centre provision. So I think that reminds us that we need to know more about how different people are using services and the kind of services that people actually want across the range of client groups. We know very, very little about care workers generally, as I said at the outset. we know even less about directly employed personal assistants. So as many of you know, if I was employing a personal assistant, there'd be no obligation for that person to be checked, to have a police check. There would be no obligation that they should be qualified, or there would be not necessarily any check that they're providing me with a good standard of care. And of course you could argue, well, that's up to me. You know, I'm an individual and I can decide for myself whether that's the kind of care I want and whether that's the kind of person I want to provide it. But on the other hand, then the potential for risk as well. And I think we also, need to be concerned about the risk, the vulnerability of the workers. So if you're employed directly by a client or by a person, a user, and you're not employed by an organisation perhaps, you're not in a trade union, then you're vulnerable as a worker as well. There's a very, very recent piece of research just that Caroline Glendinning and Rabi and other people at York have been doing about, given that so many older people are opting for these local authority managed budgets, how's that working? And so this work was commissioned by the National Institute for Health Research. And to date, the findings to date, it's quite a big study, but they've published so far research relating to 3 local authority areas. And what I've selected here is just the views of the older people themselves. So what they're saying is, we have a local authority managed budget. That hasn't actually given us much control over the agencies that provide our care, because there's not a diversity of providers within the local authority, but they were still quite satisfied with their care. They still felt that it was good. They did have some choice over their carers, so a lot of local authorities have been putting users onto interview panels, including people living in residential care, so that they could have a say in the workers who were being employed. And they felt that they had better continuity of care, so they didn't have this thing of 4 or 5 different care workers every day or every week coming into your home, that there was much more stable provision that way. What they weren't seeing was that there was a formal review of how that was working, or at least they felt that they hadn't been involved in any formal review. And overall, the authors have concluded that the intentions of local authorities have generally been good, but that there have been communication problems between local authorities, providers and users. Users say they could see the resource constraints, that they could see the difficulties, the challenges in terms of the service provision. And a number of trust issues were also used about whether people always thought that local authorities were operating in their best interests in terms of the assessment and the allocation of the money for the budget. So we're coming close to the end now. Perhaps what we lack in our policy papers, not to be overcritical, is that we don't really have strong values underpinning them. Do we know, or have we talked about what we want from personalisation? And I think, like other parts of the UK, personalisation is seen as personal budgets. So personal budgets become an end in themselves. But yet, the concept of personalisation is a much broader concept. And when the Social Care Institute for Excellence and other groups working with users asked users how you envisage personalisation, they don't generally talk about personal budgets. They talk about, older people will talk about being able to stay in the community and not to be isolated, still to be able to get out, to have contact with family, to have contact with friends. Disabled people will talk about engagement with education or with employment and so on. Now, the values, we said earlier how Wales have kind of rejected the English, what they see as the English value base for personalisation, because they see it as too market-based. And certainly some academics have been very, very critical on the grounds that they're seeing it as the potential for further residualisation of social care, that it's a way of, it will have massive consequences for a social care workforce. And we've certainly heard the unions across the UK saying that, in terms of levels of employment, wages, security and so on. But ultimately, the thing perhaps we need to think about is this idea of entitlement. And certainly several years ago now, 4 or 5 years ago, when we in the Northern Ireland Life and Times survey ran a module on attitudes to social care, we found that people were actually quite confused about how you could be entitled to health care free at the point of delivery. No question, and that's so deeply ingrained, I think, in our society. But when it comes to social care, and you're in a nursing home or you're in a residential home, that you're charged for a proportion of your care. And there is no doubt that there is a grey area there, there's a blur area. But people's automatic instinct is to reject that, that in terms of values, that they don't see why social care should be different to health service care. And we did ask people a number of questions, which was trying to get at the universal versus selective argument. We didn't just say, do you want your care free? Because, of course, everybody would say yes. But we gave people different scenarios. And there was enormous support across all age groups for a universal provision, but an acceptance that that universal provision would have to be paid for. So people were saying, well, could we pay an additional tax? Or could we have some people paying but set the payment at a far higher level? And can we see some redistribution within the system from those who can afford to pay to those who can't, and so on? So I think people accepted that there is a cost issue, and that cost issue has to be sorted. But they were absolutely in support of care which was free at the point of delivery. But apart from Scotland, in residential care, that's not the way that any other part of the United Kingdom has gone. So we have, this complex system. It's a bureaucratic system. Some people are afraid of diminishing services, I think, and that's one of their fears around this whole debate. What do we need to consider, just to finish off, and what lessons can we learn? I think we need to learn about these workforce implications. There is some data. The Personal Social Services Research Unit at Kent University collects workforce data for social care, which tells us something about the throughput in social care, about the qualification levels and so on. So there's a national minimum data set, which we don't have. We need to think about a regulatory framework for care assistants. Now, I know that in Northern Ireland is going to be the only part of the UK where care assistants have to be registered. But is that a regulatory framework, or is it just a registration process? And that's not really the point, because maybe what we need to be thinking about is how we skill this workforce and how we give it more value. And we have this debate with childcare as well, that yes, childcare is expensive. It needs to be expensive because it's trusted work. And the same thing applies to social care, so we have people going into the houses, sometimes of very vulnerable people, carrying out very intimate tasks, carrying out tasks that 10 or 15 years ago would have been done by health service staff, and they're earning just a wee bit over the minimum wage, and sometimes, in fact, below the minimum wage. So we don't know enough about this workforce. We do know that, from what we do know, care assistants in the statutory sector are better trained. They have more qualifications. They're encouraged to do training. There's a lot of diversity in the private sector in particular, so there's some very good practice, and there is some very bad practice as well, where they can't hold on to workers because of the wages, the working conditions, and so on. And it's an economic situation as well. Are you going to do this work, which is hard work? It's sometimes probably quite scary work, when you could be working in Tesco's for the same money. And what value in society do we put on that? There's the issue of balancing risk and independence. Risk is not always bad. We all have risk in our lives, and I suppose the paternalistic, there's been a paternalistic emphasis on social care right from the inception of it, which has resulted in undermining the independence of people. So we have to allow for some risk for people to make decisions and so on, but also to build in a degree of safeguarding. As we again know, and Paula mentioned being on two committees, we have this broader context, and there's tensions there between welfare reform and adult social care policy. So we have got significant issues in relation to housing and support for housing, at the same time as we're trying to encourage people to stay in the community. And it's not just housing, it's other services, transport services and so on as well. Our structure in Northern Ireland, maybe there's a question mark over whether, in terms of commissioning and in terms of provision, it's sufficiently local. So the trust areas are big trust areas, and I know that there's also the commissioning bodies linked to the trust areas, but the evidence seems to be suggesting that a lot of the commissioning is led from the central board, that it's top-down commissioning. And we've got one patient and client council for the whole of Northern Ireland as well. So it's a very centralised structure from the perspective of users, although I'm also aware there are local offices there. And then in terms of rolling this out, we need to think about whether we have sufficient resources in terms of expert advocacy and support groups, because that's been shown to make a really big difference in people's ability to achieve more personalised care. If people are very well supported, the outcomes will be better. They will stay on personal budgets for longer, taking their own personal budget, and the longer a person has a personal budget, then the better the outcomes become over time. So it's important to have that support, to get to that point. And then I've mentioned values for social care, but we also have to talk about funding. It does concern me a bit that we do see in the policy documents quite a strong rationale for doing this, is that we have demographic issues, we have cost issues, we can't afford care the way it is, and I think we certainly can't afford healthcare to be increasing the way that it is. We definitely need to be looking at public health and preventative care and so on to keep us well. But adult social care has been such an underfunded area that the concern would be whether that can be cut back any further. And if we try and make these very radical changes on the cheap, if you like, the evidence suggests that we will run into difficulties in doing that. So thank you very much.